Welcome this morning from the Netherlands. I live in The Hague and it's a gray and cloudy day today here in the Netherlands. So I put up my big tulip photo at the back to cheer up a bit. My name is Marco Blom. I'm Scientific Director of Alzheimer Nederland and also board member of Alzheimer Europe. I'm happy to chair this session because I think it's an important topic we have here. I think the group of young onset dementia people need special attention because they have special needs and problems, but they also have a big role in raising awareness and striving for better care for dementia. I will not take too much time, so we have 5 presentations in this session. I have to admit that one of the speakers is still missing, so it's a bit seeing what comes. 2 of the sessions are pre-recorded and the other sessions, presentations are live. And the presentations cover different angles from the topic and perspective, and it promises for me to be a good session. And the first speaker I will announce is Romy Van Rickstal. She's from Belgium. She works as a doctoral researcher at the End of Life Care Research Group at the Free University of Brussels. She's appointed through her pre-doctoral grant obtained from the Research Foundation Flanders, and her doctorate focuses on advanced care planning in young onset dementia, with the overall aim on developing a communication skills training for physicians.
Thank you for the introduction. Advanced care planning, or ACP, has been defined as a process of communication between patients, caregivers, and professionals in order to explore patients' preferences and values for future care, including at the end of life. When the concept arose 50 years ago, documenting an agreement between patients and physician was a primary focus. However, over time, ACP has undergone a shift in focus from documentation to a process of ongoing support in communication. The overall aim of advanced care planning is to increase the chance that patients receive care that is in accordance to their wishes, even at times when they are no longer able to express or to make their own choice. This already clarifies why ACP can be so significant for people living with dementia. Alzheimer's disease and related disorders are indeed characterized by progressive cognitive decline, which may ultimately result in decisional incapacity. Since family caregivers are highly likely to be faced with difficult care decisions at the end of life, it is recommended to involve them in the process of ACP as early as possible. Although dementia is typically associated to older age, it is estimated that globally up to 4 million people live with young onset dementia, meaning that they develop the condition before the age of 65. These younger patients and caregivers are presumed to have distinct needs and preferences in terms of palliative care, and specifically in terms of advanced care planning, mostly based on their active phase of life. Nonetheless, this particular patient population and their caregivers remain an underrepresented group in research. Additionally, studies that include people living with young onset dementia themselves are nearly non-existent. To address this truly black box in literature, we conducted a study based on the question, what are the experiences with and the views on ACP of people with young onset dementia and their family caregivers? The main message that I would like to bring to you today is that ACP that is too medicalized and that is too focused on solely the patients might actually impede engagement in the process. We found that people with young onset dementia and their caregivers rather think in an overarching framework of what matters to them now and in the future. To attune ACP to this framework, we suggest the process to be approached holistically and relationally. A good starting point for ACP in young onset dementia might just be the question, what matters to them now and in the future? Given the exploratory nature of our research question, but also given the sensitivity of the topic, we decided to conduct qualitative research. So we interviewed 10 people living with young onset dementia and 10 of their family caregivers. We recruited respondents as dyads, so all family caregivers were actually the spouses of the person with young onset dementia. Interviews were semi-structured, which means that we used interview guides, but that there was also room for respondents to address or to elaborate on topics that were not foreseen by the researchers. Verbatim transcripts were analyzed through the method of constant comparative analysis, which is actually a very inductive approach. The idea is that you assign a code to a discrete fragment of text, usually 1 or 2 sentences in a transcript, that represents a certain idea or a certain concept. And then in a later phase, you are able to identify broader themes by comparing these codes both within and between interviews. Although our respondents had made several arrangements for after death, such as planning for a funeral or making financial arrangements, we found that they had not or had barely engaged in planning medical care as part of ACP. They provided several reasons for not doing so, and these were on the one hand situational, for instance, not feeling like they had adequate information, but they were also personal. These reasons especially revolved around patient attitudes that were experienced as hindering for ACP communication. These attitudes revolved around accepting the situation, not worrying, but also not experiencing a sense of urgency to arrange matters. I provided a quote here. That's how these things go. I imagine if things get more serious, then I will get more serious too. Despite the lack of planning, both patients and caregivers actually provided hypothetical benefits of ACP, and this mainly with regard to the caregiver. So planning in advance would mean a sense of relief for the caregivers. As a female caregiver says, I have to do that for myself as well, and not just for him. We generally found that respondents were not familiar with ACP, and especially not with ACP as a communication process. Initially, our respondents directly associated ACP to making medical decisions for the actual end of life. When they were then informed about advanced care planning as a communication process, our respondents broadened their narratives to what their future might hold, and they reflected in depth about what matters to them. During this reflection, respondents paid ample attention to non-medical aspects of care and provided several meaningful insights into broader care preferences and needs in young onset dementia. These were, among others, the need to stay socially and physically active, the indispensability of autonomy and dignity within care provision, the importance of receiving high quality care, but also the interpersonal approach towards people with young onset dementia. Also here, I provide 2 quotes. The first one is of a man living with young onset dementia. I was once allowed to join in a support group for patients and caregivers. And then the first time I could be with a group. It was a meeting. And then the second time I wasn't allowed to participate anymore. Only those who were not sick were allowed in that room. And I had to make drawings, do another thing. And then I was a bit angry. I was very angry, actually. A woman living with young onset dementia explains, they get you out of bed and then they put you back in at night. And for the rest, it's done. I mean, as a figure of speech. That you are not treated like small children or anything like that. Because that's what you still see at times, right? In certain hospitals, that's what you still see. And that is not how I want to end up. No, I don't want that. We based the discussion of our study on several suggestions on how to present and implement ACP excuse me, in young onset dementia. A first recommendation is to approach ACP holistically. Our respondents actually discussed their views on care in a way that did not compartmentalize its elements, but that entailed medical, social, and mental health intertwiningly. The narrow and actually outdated conceptualization of ACP as mainly documenting end-of-life care decisions and with a close proximity to death still appear to be dominant in our sample. Since the evolved concept of ACP is actually more attuned to respondents' views and needs, the understanding of advanced care planning as a communication process needs to be increased. As such, our study also highlights the importance of reciprocity between theory and practice, because what is by now the consensus process-oriented view on ACP in research does actually not yet seem to be embraced by practice or by the larger community. Therefore, we also believe that there is a joint responsibility of practice and of policy for raising awareness and for uniform messaging about ACP as the evolved communication process it is by now. Another recommendation is that a relational instead of a purely individualized approach would hold an added value for ACP in young onset dementia. Our respondents saw the advantages of ACP more clearly for caregivers than for patients themselves. In line with other studies, ours also highlighted the potential emotional benefits ACP could hold for a family. Despite a wish for dialogue by the vast majority of our participating caregivers, ACP communication did not or really barely took place within our sample. As such, caregivers seemed confronted with conflicting demands in terms of ACP. So by protecting their loved ones' emotional needs, they actually were not able to meet their own. And to address this dilemma of possibly divergent wishes in terms of ACP, it has been previously suggested to frame the process as an act of care of the person with dementia towards the caregiver. Our results indeed confirm that people with young onset dementia themselves might regard ACP as a mechanism to help safeguard their caregiver's emotional state. Additionally, our participating patients who had made arrangements for funerals or for finances clearly showed that they prioritized their caregiver's well-being and also showed not to act or to think in a void centralized towards them as patients. This finding brought us to the concept of relational autonomy, which acknowledges relationships as an essential part of decision-making. Indeed, our study confirms that there might be a relational benefit of and a relational need for ACP in young onset dementia. For practice, we would recommend professionals to raise a dialogue about these mutually protective roles between the patient and the caregiver, since this might create a broader communicative space for ACP. This brings me back to my main message. A view on ACP that is too medicalized and that is too focused only on the patient might hinder engagement in the process. Our respondents show to think in an overarching framework of what matters to them now and in the future. And to attune ACP to their framework, we suggest the process to be presented and implemented holistically and relationally. So asking what matters to them now and in the future might be an adequate starting point for advanced care planning in young onset dementia. Thank you very much.
Thank you, Romy, for your quite interesting presentation, I would say, very relevant as well.
Thank you.
I think we can take some questions, and the question that has risen the most attention is, in Scotland, we always talk about ACP. However, many times people's wishes are not met due to lack of resources. Is that something you came across in your study as well?
Could I please ask wishes in terms of engaging in ACP or the wishes that are discussed within ACP?
I'm not sure if the person who asked the question is not able to answer this, but I would take that they express their wishes when talking about advanced care planning, but then there are no resources to meet their needs. Is it something you came across as well?
Actually, we didn't come across this finding, since we basically found that people were just not able to engage in ACP to start with. And they provided several reasons for this. But so no, we actually were not able to really discuss people's experiences with ACP because there was just a lack of engagement in the process itself.
Okay. Another question is there a role for the legal profession in this area, to your opinion?
Yes, we actually found in this study, but also in previous studies, that people who do make arrangements tend to consult legal professionals rather than medical professionals. Of course, this can be an added value, but we also concluded that it is important that there is some type of discussion or continuity of care between legal and medical professionals to make sure ACP can really be of significant meaning.
Okay, and the final question, you mentioned that relief of the caregiver was seen as a benefit of ACP. And are there specific benefits for people living with dementia themselves?
The one benefit we actually found was that people with dementia themselves, as they mentioned, but also the caregiver, do find it an added value that they can participate in decision-making themselves.
Okay. Thank you. Thank you for your excellent presentation and your answering the questions. Now we head to the next speaker. But I can say that the fifth speaker is also joining the session. So we have a full session of presentations here. And the next presentation is pre-recorded. It's actually done by 3 speakers: Louise Ritchie from the University of West of Scotland, along with Kenny Moffat and Margaret Northwick from the Scottish Dementia Working Group. And both the 3 of them are, I think, in the room. But we have a pre-recorded session, and I think Louise will be happy to take any questions afterwards.
Hello everyone, and thank you for having us here today. My name is Louise Ritchie and I work at the Alzheimer Scotland Centre for Policy and Practice at the University of the West of Scotland, and I'm joined today by Kenny Moffat and Margaret Northwick from the Scottish Dementia Working Group. Today we aim to reflect and discuss on our collaborative approach to research involvement that we've been developing with reference to a new project that we've just started working on together. I'll first start by just giving a bit of a background to the research project that we'll be working on before giving some information on the pathway that we've developed through research involvement, before passing on to Kenny and Margaret, who'll reflect on their own experiences as well. So, Dementia in the Workplace is a research programme that we've been working on at UWS for the last 8 years. Through this project, we've shown that people living with dementia can and do continue working post-diagnosis, although they do require support, and that support has to be specific to their job and given at the correct time as well. So our new project is this last one here on the slide, is co-producing a careers guidance intervention for people with dementia. This project aims to develop an intervention that will help support people who are diagnosed with dementia whilst they're still in employment, and we'll look at helping them to sustain their employment and or look at other opportunities for employment post-diagnosis. I've been working with the Scottish Dementia Working Group since 2019 on the development of this idea. The intervening period there between 2019 and today, we've obviously had a pandemic and lockdown, which has delayed the start of this project significantly. But in March 2021, we got the good news that our project had been funded by the Alzheimer Society, and we were ready to start in October this year. So in June 2021, in the picture shown on screen there, I went back and met with the group, and we spoke again about the development of the project and how we might manage our involvement process to that. So this project has had points of involvement all the way along. We've been working closely with Margaret and Kenny specifically to work on this presentation as our first collaborative activity within the project. And we're looking forward to seeing how our working relationship develops and what happens next. So I'll pass on now to Margaret and Kenny, and we'll discuss their perspectives and their reflections on it. So welcome, Margaret and Kenny. Do you want to quickly introduce yourself before we go any further?
Yes, surely. I'm Margaret Northedge. The work that I have been doing is my management courses that I used to deliver, and I was really quite happy in my work. I was getting on fine. I was one of the seniors in the team in the training department, and I realised that I wasn't just as switched on as I would like to be. It came to a point where I just had to take the decision that I was going to resign, and that was it. And I resigned, and then after that I realised that work had gone and there was a vacuum there now, and I didn't know what to do with myself, and I went into a period of quite bad depression after that. And it was actually once the dementia groups picked me up and gave me another focus. And, you know, I haven't looked back. I really didn't think I would get involved in groups like this. But, you know, it's a new world for me and I love it. And I've met so many people and done so many things. It has been fantastic. I can't say more than
Great, thank you, Margaret. And Kenny, do you want to just introduce yourself?
Yes, good afternoon. I'm Kenny Moffat. I'm 55. I was diagnosed with young onset at 50. I had known, like Margaret, I had known that I wasn't performing at work as well as I would have expected. As outside work as well, I was struggling with reading, watching television programs, and just felt there was something not quite right. So I took the decision to retire, and felt like Margaret that it was the beginning of the end. But in fact, it wasn't. It was the beginning of a new beginning. I had struggled for probably a year without a formal diagnosis. But getting the diagnosis meant that there was something that was wrong, and that I could do something about it. I didn't know at that time what. I now know what, because of my involvement with Alzheimer Scotland and with the working group. I know what I can do to make life meaningful and productive.
Thank you, Kenny. And I think you both explained that you've had difficult experiences with your work as you were diagnosed, which makes your experience really relevant for the project that we're working on now. I wonder if you could say a wee bit about what you research involvement means to you, as well as alongside this project and being involved in this project.
Well, actually, when I got involved with the dementia working group, it was brilliant because it was like going back to work again, and you had a purpose, and you know, you concentrated things and you thought about things, you know, offline as well. But, you know, you're thinking about all these things and how we can make things better. And it really is about your own self-worth and what you can contribute to society still. And because I don't want to sit in a chair all day.
Yeah, exactly. Thank you. And Kenny, do you have anything to add on that?
No, not at all. I agree entirely with what Margaret said. Being involved in the research makes me feel meaningful. It means I'm contributing to work on an issue that's important to not just Margaret and myself, but the rest of the group.
Yes.
We are a campaigning group, and we do together discuss a range of issues and how we feel about them. And we always feel that our interactions are meaningful.
Mm-hmm.
We don't have to agree with one another, but
Mm-hmm.
we can agree not to agree and
Mm-hmm.
explain why we don't agree.
Yeah.
And it's about that meaningful interaction. And like Margaret said, it is like being back at work. It's having a positive and meaningful task to undertake. So being involved in the research means that you're making a contribution, a valid contribution. So in a personal sense, I'm giving something back.
Yes.
And getting something from it.
Yes. Well said.
So you said that being involved in the research was a way to feel as if you're meaningfully doing something that's going to help.
Yep.
And help influence the way forward, and people who are maybe experiencing similar experiences to you had. And I just wonder, before we finish up, what are the challenges, do you think, to getting meaningful involvement and making sure that the contribution that you have to a project is valid and is taken on board?
Yeah. Well, I think we need to change people's perceptions of Alzheimer's, because when you hear Alzheimer's or dementia and things like that, people tend to make assumptions that you don't understand and that you wouldn't be able to follow a conversation, you wouldn't be able to think for yourself, etc. And we need to dispel these myths. You know, we're all at different points in our dementia, and some of us are further along and some are just joining us. And we have to take everybody on board when we're campaigning, because everybody's got something to say.
Thank you. Yeah.
And some involvement can be tokenistic. Sometimes you can feel that you're asked to take part in something just so that a box can be ticked. But as Margaret says, it has to be understood that despite our diagnoses, we still can make a meaningful contribution, and we still can be heard and need to be heard, not individually, but on behalf of our community, because we are part of a community. There are over 90,000 people in Scotland living with dementia. That was prior to the pandemic. We're sure that when the pandemic eventually eases, that there will be a raft of, I keep saying, a tsunami of new diagnoses, people who have not received a diagnosis during the time of the pandemic because they haven't been able to see a consultant or see their GP. And all of these people are going to suddenly join our community. And many of them will be younger. Many of them will be in a similar position to Margaret and I in terms of working, and will face the same issues. So the challenge that you asked about is really making sure that our contributions are not considered to be tokenistic, that we're not just ticking a box. Because of the diagnosis that we've received, and that it's understood that we can make a meaningful contribution despite the condition that we live with.
That's right. Yes.
Thank you both, and I think that's a great point to end on, and I think that's it's why I'm so excited about taking this project forward as well, because all our research to date has been showing how meaningful a contribution and how able people are to still contribute in a variety of ways. So it seems like a perfect relationship to build on and develop. So thank you so much. And I think we'll now go to questions for the presentation. So thank you.
Okay, thank you.
Thank you.
Well, thanks for this impressive presentation, I would say. Great work. And I should share the compliments of the audience, especially thanking Margaret and Kenny for sharing their stories and being supportive to others who are in the work environment and struggle with their situation. I was personally very impressed by the fact that they found a new career, both Kenny and Margaret, by joining the Scottish Dementia Working Group and being involved in research. And I think that serves as an example for many of the Alzheimer associations throughout Europe, for instance. So very impressed. Take some questions. I think one of the questions is, how do managers on the work floor, as we say it in the Netherlands, how do you receive a training on dementia to help them understand and, well, support people while being at work? Can you tell us a bit about that?
So as far as we know from our research so far, that doesn't really happen. It happens sporadically. So there's some work going on in Scotland with Age Scotland and Alzheimer Scotland, where employers and organisations can access training for them, but it's very much they need to realise it as being an issue before they access the training. The training doesn't happen as standard in workplaces, so it is very mixed in the experience that people might have if they're diagnosed. And it's quite often if an employee is diagnosed, then the employer will go looking for training. So we're hoping that this new project will start to try and address the gaps and improve the support that people get.
Okay, thank you. Now we have to move on to the next presentation. Thank you, Louise and Kenny, Margaret. The next presentation is from Esther Gerritzen. She lives in the United Kingdom, but she's originally from the Netherlands. She's a PhD student at the University of Nottingham in the UK. She has a background in public health. She's now enjoying, I think, the Marie Curie Action Fellowship, and she's part of the Distinct network. And for her PhD project, she looked into the online peer support for people with young onset dementia, the topic of this presentation. Esther, the floor is yours.
Okay, yeah, thank you very much for the opportunity to speak here today. Today I will indeed present my work on peer support through Zoom and the experiences of people with young onset dementia. And I worked on this together with my fellow PhD student, Gianna Cole, and my supervisors, Dr. Ori McDermott and Professor Martin Orrell. So today I will talk about what online peer support is, why we did this research, how we did it, what did we find out, and finally, what are the implications? So first, what is online peer support? Well, peer support is actually any contact between people who have a similar life experience or share a similar health condition. And in this case, that's young onset dementia. And there are three key elements that can be associated with peer support. So the first one is experiential knowledge. And this means that this is unique knowledge that people have because of their own personal experiences, or in this case, living with young onset dementia. The second one is reciprocity. And within peer support, people can develop a relationship in which they can receive support from others, but they can also provide others with support. And this is very different from, for example, a professional relationship where someone with young onset dementia only receives support from the professional. And the final one is social support. Because people within peer support have similar experiences, they can provide each other with support, they can understand what the other person is going through, And this is really unique to peer support because this is the kind of understanding that, for example, other friends or family members or healthcare professionals simply do not have because they don't have the same condition. So peer support can happen in person, for example, through peer support groups in the community, but it can also happen online. And this is something that especially became more popular during the COVID-19 pandemic. There are different things that we have to keep in mind when thinking about online peer support. And the first one is the type of platform. And online peer support can happen in many different ways on different platforms. So there are open platforms and also private platforms. So open platforms could, for example, be Twitter or open discussion forums that are accessible to anyone. Whereas private platforms could, for example, be private Facebook groups or Zoom meetings that are only accessible to the members. Then we have to think about the mode of communication. So communication can be synchronous, which means it is in real time, for example, like we're doing now, or asynchronous. And this is often the case, for example, on Facebook or Twitter, where someone can post a message and another person can respond at a later time. And then communication can also be written or text-based, or it can be verbal. And finally, we have to consider moderation. And a moderator can either be someone who, for example, monitors posts in a Facebook group or a discussion forum, but it can also be someone who guides the discussion, for example, in a Zoom meeting. And a moderator could either be a healthcare professional or another professional. It could be a lay person or someone who is also a member of the group. And in some cases, sometimes on social media, there's no moderation at all. So why did we do this research? Well, through conversations with people with young onset dementia and their supporters, and also through literature research, we identified some gaps in practice and in research. And the first one is that there is a lack of age-appropriate support services for people living with young onset dementia, especially in the UK. And this is also the case for the availability of local peer support groups that are age-appropriate. And the availability of support also varies very widely across the UK, with some areas having excellent support services and some areas having hardly anything at all. Secondly, we identified a lack of research into the personal experiences with online support. And there's more research in online peer support, but this often focuses on, for example, posts that are being shared on an online platform. And this doesn't tell us very much about how the users actually experience this type of support. And finally, there have been COVID-19 related challenges. And during the pandemic, many in-person peer support groups were forced to move their meetings online, and they really had to sort of learn with trial and error how to adapt to this. So how did we do our research? For our research, we conducted focus group studies with existing peer support groups that were meeting online during the COVID-19 pandemic. And some of these groups met in person before, and some of the groups never met in person before and were always online. So the participants were people living with young onset dementia, and we conducted 4 focus groups, all online, and we had 20 participants in total. And for the focus groups, we used the group's usual meeting platform. So for 3, this was on Zoom, and for 1, it was on GoToMeeting. So what did we find out? Well, many people spoke a lot about the difficult time they had after receiving the diagnosis, and also the challenges they faced when looking for support. And actually, many things are very similar to what Margaret and Kenny shared in the presentation before. People spoke a lot about the challenges they especially faced when looking for support. One person shared, "We lost our jobs, we lost our driver's license, you lose your independence. And the thought of joining a group of people when all you've had is your confidence kicked down, it's really pretty hard." And people also spoke about how difficult it was to find age-appropriate support and some of the negative experiences they had with peer support groups that were joined by people who were sometimes maybe 20 years older than them. And one person shared, I didn't realize that there was a group that was very similar in age, similar diagnosis, etc. I expected, like, you know, a group, it would just be for older people in their 70s and 80s. Another theme that came across was mutual understanding and support. And people really felt a sense of connection with their peer support groups. And they shared that often, initially, it was quite difficult to join a group and they were a bit hesitant, but they mentioned that once they did, it was the best decision ever. One person said, I started to gain a huge amount of friends who don't judge me. They accept me for who I am. They laugh with me and not at me. And besides the friendship and mutual understanding, people also gained a lot of information from their peer support group. Often this was information on local support services, where to find legal or financial support, and so on. One person said, after a few weeks, I found out I got so many things, information and stuff, which I knew nothing about, and only through the group that came about. And finally, one person said, there's lots of things that we don't have to say to each other because we live in the same fog. And I think this quote really highlights a key aspect of peer support. And that is the kind of understanding that, as I mentioned, other people simply cannot provide because it is because of this unique experience of living with a similar condition. That really makes peer support so powerful. So there are also some specific benefits that can be related to peer support online. And most of those were related to the challenges of COVID-19 because in-person contact was just very difficult and limited. And online support was a way to stay connected for many people. One person said, Zoom opened up the world to me. It's kept us as a group in contact with each other. It kept us busy and kept our minds going. And it really highlights a sense of continuity of social contact during a very difficult time. Maybe a time where social contact and support was more needed than ever before. Online peer support also overcomes geographical barriers. It makes it possible for people from different parts of the UK or even different parts of the world to connect with each other. And one of the support groups, they had members from all over the world, and they actually never met in person, but they knew each other through Zoom. One person said, we've met lots of people we wouldn't have met were it not for Zoom. And finally, peer support is a convenient way of communicating with a group. And it also makes it unnecessary to travel because people can join from the comfort of their own home. And in one group, a person mentioned that she was quite hesitant of joining a peer support group and found it quite daunting. But being able to do it from her own home, having her pets there, really made her feel comfortable and took away a barrier of joining a support group. However, there are of course also some limitations to online support, and the most frequently mentioned one was that it cannot fully replace in-person human interaction. One person said that while Zoom meetings are good, they're not the same as meeting people and having cups of tea, eating biscuits, and just doing that human connection thing that is so important. And many people mentioned that they were really looking forward to being able to meet up in person again. Another theme that came across was the digital exclusion. And this was especially true for groups that used to meet in person and noticed that some people were able to join the meetings on Zoom and some people were not. And one person said, the sad bit is that several members of the group can't access Zoom or Teams or any other online aspect. I really feel a loss for the folk who have just not had the same connection or the same continuity that some of us have had. And people also mentioned in relation to this, having clear guidelines, for example, on how to access the Zoom meeting, having a very organized facilitator, having support maybe in installing Zoom or Teams. It's just very necessary and helpful to participate in peer support online. So what are the implications of this research? Well, our findings show that some of the benefits of in-person peer support groups can be transferred into an online setting. This was especially true for social support, emotional support, friendship building, and so on. And online peer support allowed people to stay connected during the lockdown in a time where support was more needed than ever before. And online peer support can also open up new opportunities to meet people from different parts of the country or the world. And it can be especially useful for people who do not have an in-person support group in their local area, or who maybe are not able to travel. However, technology and online platforms cannot fully replace in-person human interaction. And also digital exclusion remains an important limitation. And in that sense, having technological skills, having support, and clear guidelines are very important. We also identified some directions for future research. The first one is to explore the experiences of those who do not or cannot access online peer support. And everyone who participated in our study was able to access online peer support. So it's really important to explore the barriers to online peer support as well, so that we can identify these and also see how we can overcome these and how we can support people better. And finally, we need to explore how people experience different types of online peer supports, because as I mentioned, there are many different types. And in this study, we only looked at real-time communication through video conferencing platforms. And it will be very interesting to see other types of online peer support and how people experience those. So yes, here are the acknowledgements, and I want to especially thank all the participants and the organizations that supported the study. And yes, if you have any questions, I'm happy to take them now, or you can contact me. Thank you.
Thank you very much, Esther, for an excellent presentation. I saw a lot of compliments coming in at the Q&A. I've only room for one question, so I would like to ask you, what is the added value, 3 points, of online peer support instead of face-to-face peer support?
I think the added value, the main one, is that it overcomes geographical barriers. So for people who cannot travel to an online peer support group, for people who don't have an age-appropriate support group in their local area, it can really be an added value. Yes. Okay. Yeah, that I would say that's the main benefit, and especially during times of crisis and lockdown where we cannot meet in person. We need more support more than ever, and online peer support can help people.
To stay connected. Yeah. Okay.
Exactly. Okay.
I would personally like to hear more from your presentation, because we have a big online platform in the Netherlands, and maybe we can learn from you and your experiences. But I'll do that question taking afterwards. Thank you very much.
Yeah, great. Thank you.
Okay. So we go to the next speaker, that's Suzanne Gray. She's a registered mental nurse with over 30 years of experience. She's currently working as Alzheimer Scotland Dementia Nurse Consultant, but she's also clinical doctorate student at the University of Stirling. And she will be presenting on living with a diagnosis of frontotemporal dementia, what helps and what hinders.
Thank you. So good morning, everybody. I hope everybody's safe and well, and many thanks for the opportunity to talk about my study today. Can we go to the next slide, please? Thank you. So just to provide a bit of context, I always knew that if I was going to study at this level, that it would be about frontotemporal dementia, and that's very much based in my clinical experience of supporting people with FTD, and very similar issues which other speakers have spoken about this morning. So problems with accessing appropriate services, people experiencing a poor journey with FTD, quality of life not being as good as it should be, and very often early institutionalization. So that's the reason that I chose to study about FTD. Next slide, please. So as part of the clinical doctorate, programme, the first 2 years are taught. So part of that involves a literature review. And I think what's important to note here is there were only 13 articles, so there were 7 databases searched, and 13 articles met my inclusion criteria. So 10 of those 13 articles were from the family carer's perspective. 3 of the articles were from 9 articles were from the carer's perspective. 3 were from the staff perspective, but I could only find 1 paper that actually was the person's perspective. So the one paper that I did find was by Griffin et al. In 2015, and although similar themes have emerged in my study, there are also important additional themes and slight differences which in my study have emerged, which I think could have a significant impact upon clinical practice. So very similar were the threats to self, this is not me, that came up in my study, and the relationships with others also come up in the study. But within my study, rather than relationships with others, it was about roles, and in particular the working role and the loss of the working role, which has already been discussed this morning. And just to point out that my study is different to the study of Griffin, in that my study wasn't limited to people only with a diagnosis of the behavioural variant of FTD. My study included people, there were 7 participants, and only 1 participant had actually been told which subtype of FTD they had. So I have no way of knowing what subtype the other 6 people had. So that could be construed as a strength or a limitation. So the aim was to explore and understand the experience of living with a diagnosis, and that led to 2 research questions. So how do people with FTD describe their daily experience of living with FTD, and what do people with FTD feel helps and hinders them to live well with the condition? So there were lots of recruitment issues. It was very difficult to recruit people with FTD. It took a long time, and I had to rethink my recruitment strategy. So there were several ethics panels that I had to satisfy. So just to introduce the 7 people that I interviewed. So there were 7 people, which culminated in 13 interviews. And although I thought that the interviews would be a lot shorter than 1 to 1.5 hours, that was the average length of each interview. And you can see from this that the age range of participants was from the age of 52 to 68. And again, this looking at the employment status of participants. Of those 7 people, 4 had retired prior to receiving a diagnosis because they suspected that they were having difficulties at work and didn't have a lot of support. And 3 people immediately gave up their employment at the time of diagnosis. And that had some pretty devastating effects on those 3 individuals. So the methodology that I selected was interpretative phenomenological analysis. And basically that's underpinned by 3 areas of philosophy. So phenomenology focuses on the subject matter. So basically, in order to understand what that individual has experienced, the researcher must, in a sort of methodical way, approach and experience that phenomenon as directly or as fully as possible. Hermeneutics is the theory of interpretation, and it refers to the idea that your understanding of the text as a whole is established by reference to the individual parts. So neither the whole text or any individual part can really be understood without reference to one another. So it becomes this hermeneutic circle. And IP acknowledges that researchers' understanding of the experience is filtered through what people reveal. So this double hermeneutic approach occurs in order to interpret the account from the individual and try to understand that experience from that one person's point of view. And ideography is concerned with a particular, and in IPA there's a need for a depth of analysis. So consistent with IPA, I went with semi-structured interviews, and the interview schedule was designed with collaboration with a group of people with dementia. The interviews were audio recorded. They were roughly about 2 weeks apart. And the reason for 2 interviews initially was because of potential attention or concentration issues. And as I said, I thought would be shorter interviews, but it turned out they weren't. But it was also a really good decision to make for me as a novice IPA researcher, because it gave me the opportunity to immerse myself in the data, look at where I should have probed a bit further, and then ask those questions at the second interview. But I think it also enhanced the relationship that I had with the participants. As I say, there were 13 interviews in total. So the analysis, I followed the guidance from Smith et al. 2009. So I transcribed myself and did a line-by-line analysis, identified emergent themes across each interview and then cross-interview. And the development of these themes continued throughout the process, right up until writing the thesis. So this is just an example of that analysis. So the middle column is the transcription. And the right-hand side column, that shows you the 3 levels of analysis. So where the writing is in plain font, that's the details, the facts that have been stated within the interview. If it's underlined, that's my interpretation of what is being said, of me trying to make sense of how that person is making sense of their experience. And if it's in italics, that's the linguistic analysis. Are there any rhythms, gaps in the person's speech? Are there repetitive words? Are there any high emotions? And from there, if you go to the column, the first column, that's the beginning of the development of the emergent themes. So the refinement of themes went on, but finally came to 4 superordinate themes. The first one was the rocky road through assessment. And that's not just medical diagnostic assessment, that's accessing benefits, fitness to work, driving assessments, that's any type of assessment. The changing self is about that sense of change. And one of the differences I've found to the wider literature in this group of people was that they didn't consider the future self, and that has implications for anticipatory care planning. In touch with reality, in comparison to the Griffin study, I found that 7 participants had really high levels, consistently high levels of insight and awareness. And what struck me was that the issues concerning risky behaviour and decision making was more a processing issue, so people could reflect fully and tell you about other people's points of view and why their decision had been risky, but they couldn't take that knowledge and apply it to a similar situation in the future. So for me, it was more about a processing issue. And the last superordinate theme was this keeping going. So this having a positive state of mind, and very importantly, someone being there for the person. And interestingly, all 7 participants lived with someone and had 24-hour family support. And I think that is significant. I think it would be very interesting to try and find people who were living alone with FTD. So there were 2 overarching themes. You can see them in the diagrams. So hearing the voice is probably the most important finding of this study, in that people with FTD can articulate their experiences. We absolutely need to include people and place them at the centre of future research, and in doing so, hopefully we will enable people with FTD to exercise some control over their journey, which is extremely important. So the findings, lots of findings, but there's a need for person-centred assessment. There's a need to look at how we support people to maintain their working role. There are many clinical implications for staff about how we help people with FTD to manage their own emotions. As I've said, I found that there were high levels of insight and awareness, and that processing was an issue rather than insight and awareness. Not planning ahead has implications too. But the thing that struck me most as a nurse who had been out doing assessments on people with FDD, was what my participants said was that the symptom that caused them the biggest problem in maintaining their quality of life were actually the physical symptoms of FDD, which is something that I'd never considered, even as an experienced nurse. So some quotations here. I won't read them all for you, but going back to the processing issue that I mentioned, I'm just going to read out the third quote to you. And this is about a gentleman who had pulled his car over on the motorway and was refilling the windscreen wash and was veering onto the actual motorway, and his wife was in the car with him. So, you know, but and she could not convince me all through the day that that was the wrong thing to do. So she just had to leave it. And then as time goes by, she thinks, I can talk about it together and I can see how dangerous that was. But even just now, at the back of my mind, I think it wasn't all that dangerous, but it was. So you can see that transfer of knowledge issue. So challenges for me were trying not to go into the nursing role and not to try and help people problem solve. Ongoing concern about the participants. So as a nurse, you have that ongoing relationship. As a researcher, you don't. Personally, I find that very difficult. And networking, which I find quite challenging, but basically the key point was that I think the findings are so important that I can't just sit in my comfort zone, hence the reason I'm here today. Next slide, please. So dissemination, I'm hoping to get some papers published. I'm here today and I intend to contact particular groups. I do think there's a need for a political awareness about FDD, particularly in terms of accessing benefits and retirement pensions. And I think there is absolutely a need to influence and make changes in practice. So in the future, this is just a start, just to keep going. There's an absolute need to increase the awareness of all people about FDD and a need to develop future interventions around what we know about the views of people with FDD and to collaborate with others. So thank you very much for listening and thanks again for the opportunity to speak about my study. Thank you.
Very much, Suzanne, for your talk. Because of time, we need to move to the next speaker. But having said that, I want to compliment you with your results on the lived experience of all the people you interviewed, and you tapped on things like loss of working role, changing self, keeping ongoing, which was very nice to hear the more positive side of the people mentioning in the interviews. So thanks. But we have to move on. So the last speaker is Stevie Hendriks. It's a pre-recorded presentation, but I know Stevie's here. She's a PhD student at the Alzheimer Center Limburg. It's part of the Maastricht University in the Netherlands. And her research is part of the Dutch Pre-Code Consortium, which studies, among others, prevalence and incidence on dementia with young onset dementia. So Stevie, I give the floor to you.
Hi everyone, my name is Stevie Hendriks. I'm a PhD student at the Alzheimer Center in Limburg, which is part of Maastricht University in the Netherlands. And today I would like to talk to you about a review that we did on the global prevalence and incidence of young onset dementia. A little bit about the outline of this presentation. I will talk to you about our systematic review. I will say something about the background, the methods, the results that we found, and the conclusion. And then I would like to go into a little bit more depth on the implications for healthcare that our results have. So let's just begin. First, small introduction. When I talk about people with young onset dementia, I talk about those people who have an onset of the symptoms of the disease before the age of 65 years. We don't know a lot yet about the epidemiology of young onset dementia, but this is very important to understand because it helps us to further research the etiology and also risk factors for young onset dementia. But it also helps healthcare policymakers to be able to improve the healthcare for this special group of people. And therefore, we aim to systematically review all the data that was available on the prevalence and incidence of young onset dementia, and to meet to analyze the results into pooled prevalence or incidence estimates. How did we do this? We used the MOOS guidelines for our review. and we used 4 databases to get the studies that we wanted to include. And the search strategy that we used in these 4 databases had 4 blocks on the dementia part, the young onset of the dementia part, the epidemiology, so the prevalence and the incidence, and the kind of studies that we wanted to find, which were population-based studies. The studies that we wanted to include had to be published between January 1990 and March 2020, and there were no language restrictions on the studies. And our review is registered at Prospero. We had some in- and exclusion criteria for our studies. First inclusion criteria was that they had to have information on the prevalence or incidence of dementia in people under the age of 65 years. Maybe a little bit obvious, but still. Studies had to be population-based because we wanted to extrapolate all the data to the general population. And then studies had to be observational, either prospective, retrospective, or cross-sectional studies. Exclusion criteria were studies that were conducted in care homes or studies that were conducted in specific patient cohorts, because these are not general populations. So if you have, for instance, a study only including people with Parkinson's disease and they are looking for the prevalence within this cohort, then the prevalence that they find is not, we could not extrapolate it to the general population. So that's why they were excluded. And also studies based on mortality data were excluded. Then we did statistical analysis on the studies that we found with random effect meta-analysis. And we did these meta-analysis on 5-year age bands. So we started at the age of 30 to 34, and then all the way up to the age 60 to 64. We did some subgroup analysis, and I will come back to that later in the results section. We age standardized the results that we found for the world standard population, the European standard population, and the American standard population. And we did meta-regressions to look at heterogeneity between the studies. Then for the results, so as I said, we looked at 4 databases and we found over 19,000 hits in these 4 databases, but there were some duplicates, and after deep duplication, 11,000 hits remained for screening, and we ended up with 145 articles that had information on prevalence and incidence, 95 on the prevalence of young onset dementia, and 50 on the incidence of young onset dementia. And of these 95 on the prevalence, 74 were included in meta-analysis, and all 50 studies on the incidence were also included in the meta-analysis. So first for the prevalence results, what you can see here is a world map which shows where the studies that were included in our review were conducted. So you can see that still a lot of countries don't have any information on the prevalence of young onset dementia. So these countries are missing in our analysis. And then for the main results, so we looked at the age ranges in 5-year age bands from 30 to 65 years old. And then you can see here in this column the crude prevalence estimates that we found. So you see that the prevalence estimates increase with age. And then you can see what the prevalence estimates are when standardized to the world standard population, the European standard population, and the standard population of the United States. And then you see again increasing with age up to a world standard population in which the prevalence was 119 per 100,000 people. And this 119 per 100,000 people corresponds to 3.9 million people worldwide living with young onset dementia. As I mentioned before, we did subgroup analysis. We looked at gender, and we found that there was no difference between males and females in the prevalence of young onset dementia. We looked at some dementia subtypes, and we found that the prevalence was highest for Alzheimer's disease, followed by vascular dementia and frontotemporal dementia. These were the only subtypes that we had information on to meta-analyze. So other subtypes we did not have enough information to look into. Then we had the economic status of the countries, and we found that prevalence was highest in the countries that had upper middle income economic status, then lower middle income countries, and then the prevalence was lowest for high income countries. And then finally, the study design, we found that studies that use a cohort design found higher prevalence estimates than studies that use a register-based design. And then for the incidence, we again made a world map where you can see that even less countries have information on the incidence of young onset dementia. So even more countries have missing information here. And here again, the main results, again, for the age ranges 30 to 64 in 5-year age bands. And again, you can see here the crude analysis, and you see that the incidence rates also increase with age. And we again age standardize them, and then you can see that for the world standard population, the total incidence is around 10 per 100,000 person years. And this then corresponds to 350,000 new cases of young onset dementia worldwide every year. Also for the incidence results, we looked at subgroups. Again, gender, there was no difference between males and females. Also, again, dementia subtypes, and we found that as the same as in the prevalence estimates, Alzheimer's disease has the highest incidence rates, followed by vascular dementia and frontotemporal dementia. And when we looked at study designs, we found that the incidence was highest for prospective cohort studies that used active case finding. So they actively screened the people for dementia. Followed by prospective cohort studies that use register linkage. So they looked at dementia diagnosis in registers. And finally, incidence was lowest for studies that use retrospective register-based studies. So retrospectively looking in registers or databases to see if someone had a diagnosis of young onset dementia. So as a conclusion, we can say that age stratified analysis showed that young onset dementia increases with age, the prevalence increases and the incidence increases with age, but data is still scarce, especially in low income countries, as we already saw in the world map. There was not a lot of information on the prevalence and the incidence in low income countries. There was also still not a lot of information on the prevalence and incidence in lower age ranges. These results were based on only 3 to 4 articles. And there was also still not a lot of information on male and female discrepancies. So these are things to look into in future research. And then finally, for the implications for healthcare. So we found that 3.9 million people are living with young onset dementia worldwide, and these people need tailored healthcare. And so we hope that this review shows policymakers the need for more and better healthcare for this special subgroup, because current healthcare is usually tailored to elderly people with dementia, and so it doesn't always meet the needs for the young people with dementia. We also hope to raise awareness for the fact that dementia can occur at a young age. So increased awareness in the general population can help people with young onset dementia, but also their caregivers to feel understood and supported. And last but not least, we hope that this review is a starting point to also increase the recognition of young onset dementia by healthcare professionals. Diagnosing young onset dementia is difficult, and it takes usually a long time before someone gets a diagnosis. And we hope that increasing the awareness through this review is a first step in increasing the recognition of young onset dementia in healthcare professionals. So this is what I wanted to talk to you about today. Thank you very much for listening. And if you have any questions, I'm happy to answer them. Thank you very much.
Thank you, Stevie, for your presentation, pre-recorded. There seems to be a burning question in the Q&A, and that's on the difference between Europe and US in the prevalence age of 60 to 65. Can you explain this difference?
Yes, thank you very much for the question. Yes, I can definitely explain this. Because what we did was we looked at the the European standard population and the American standard population. And what you see is that the European standard population is older. So there are more people in Europe living in the age range of 60 to 65 years than there are in the United States. And then if you look at the prevalence there, it is higher because there are more people living in this age range. So then also the prevalence of young onset dementia in this age range is higher. So it's not that there is a difference in risk factors or anything. It's just a difference in the way that the population is structured.
Okay, thank you. I think I see a lot of compliments for your work. Impressive. I think it has been breaking news. The article you had on prevalence and incidence, I think. And
yeah,
I think it's a nice piece of research you've done there with your team. I have to conclude this session, but I would like to say that I think on behalf of the participants, I would share my thanks to all the presenters. I think we had a very lively session. It came from different angles and perspectives, but I very much like the combination of data and statistics versus the lived experience of people with dementia. And I think that's a very powerful combination in getting on in this topic and make sure that we keep on going, as the people with dementia themselves said to us. And maybe to end with the quotation of, "We live in the same fog." That was a very, people liked the quotation very much. And I think in a way, it is more or less the umbrella theme of our session, because we need to look for the differences the people experience and help them to keep on going in this same fog. So I would like to thank the presenters and the participants for being here in the session, and I wish you a very nice second half of the day and the last day of the conference. Thank you very much.